Sorry, just hang on one sec.
I'm gonna mute myself while you're talking.
Okay, perfect.
I'm just gonna tell people.
Okay, good. All right. Okay, so hi everyone. I'm Terrie Foster. I use the pronouns she, her, and hers. Dr. Chin-Yee and I are here today to chat with you all about culturally safe care for trans and non-binary people, about the successes that we have had in our practices, the challenges, as well as the opportunities. So the objectives of this talk, we're going to talk about key terminology and current challenges in providing culturally safe care for trans patients and blood donors. And we're going to describe cultural competency and cultural safety principles and best practices to improve trans patient care and donor care. And then we're also going to talk about future opportunities at Canadian Blood Services and in the transfusion medicine community to practice cultural safety and to encourage diversity and inclusion. So first, we're just going to go over some general terms. So trans is an umbrella term that's used to describe individuals whose gender identity differs from the sex assigned to them at birth. And this can include, but is not limited to, those who are transgender, or trans men, trans male, or trans masculine individuals. And those are people who were assigned female at birth and they identify as male. Or trans women, trans female or trans feminine people. And those are people who are assigned male at birth and identify as female, as well as non-binary, bigender, gender fluid individuals. And those are individuals whose gender identity is not dichotomous or exclusively male or female. And so for the purposes of this presentation, we will use the term trans to include all gender diverse identities, including non-binary people. And then one other term to be familiar with is cisgender. So cisgender individuals are individuals who are not trans, those whose gender expression and identity are the same as the sex they were assigned at birth. So just a few more terms. So sex refers to a person's status as male or female, or intersex based on biological or physiological characteristics. Sexes are usually assigned at birth just based on simple inspection of the genitals of a newborn baby. And sexual orientation, it's important to understand that sexual orientation is not the same as sex. Sexual orientation means who a person is attracted to. And just like everyone, trans people can have any sexual orientation. They can be gay, straight, bisexual, and their partners may or may not be trans as well. So gender identity is a person's intrinsic experience of gender, being man, woman, neither, both, or anywhere along the spectrum. And it's important to consider that every person has a gender identity. It may be the same as the sex assigned at birth, or it may be different. So gender expression is the outward expression of gender identity, which may be congruous or incongruous with societal and cultural norms regarding the characteristics and behaviors commonly identified as feminine or masculine. And it's important to consider that not all trans individuals express their gender by undergoing a physical transition. So through surgery or through medication or through changing their dress or appearance. And the decision to physically transition is really individual for each person. Some people might expect that they'll just know if a person is trans by how they physically look, and they might be surprised to learn that this isn't always true. So this really means that you could be interacting with trans individuals without even knowing. And it's why it's important to be an ally and a supporter, even during times when you think trans people are not present during your discussions. So in terms of population estimates, accurate population estimates of the number of trans people is really a challenge because many data collection platforms aren't inclusive with identifying these individuals. The most widely used and reported stat is one by Flores and colleagues from 2015. And this was done through the Williams Institute, and they found that 0.6% of the US population identifies as trans. And really this number is most likely an underestimate. There was also a study done in 2015 called the US Transgender Survey by James and colleagues. And in the study, they found about 1/3 of the 28,000 trans people who had responded to the survey identified as non-binary. So that's a really significant number. And Canadian Blood Services has more than 350 self-identified trans donors, and this number is increasing. So when we use the term culturally safe care, what does that mean? So cultural safety extends beyond the idea of cultural competence. Cultural competence is more of a term that we use regularly in healthcare, which is defined as the ability to interact effectively with people of different cultures. But cultural safety involves a deeper dive beyond cultural competency to really understand biases and the power differentials within society and within ourselves that can hinder effective relationships, that can uphold cultural oppression. So when looking at culturally safe care for trans people, it's really important to think about the social and cultural narratives that shape our understanding about gender roles, and gender expression, and what that means and how our preconceived notions about these things can potentially create barriers to effective relationship building with trans people. So cultural safety is really about addressing these barriers and transferring the power back to cultural groups, which really facilitates truly meaningful relationships that are the foundation of appropriate and safe care. So, oh, you're on mute, Ian.
Thank you, Terrie, for that introduction of the terminology and particularly the idea of cultural safety. I wanted to share with the audience now a reflection that was written by a medical student. And this reflection actually caused me to reflect on my own cultural biases. And I hope many of you will recognize yourselves in this. So this medical student was in 3rd year at the time, and he was rotating in clerkship through the gynecology service. He's now a family doctor, and gave me permission to use his case. This is the reflection he wrote. I was asked to see a gynecology consult in the emergency room on a Saturday afternoon. The patient was a trans man. He had his female pelvic organs removed 2 years previously and had just returned from sex reassignment surgery done 2 weeks ago. Unfortunately, the phalloplasty attempted was unsuccessful, and the infection was now spreading and had to be debrided. He and his partner were dejected. He'd waited 5 years for this surgery and was now facing complication after complication. Even worse, the healthcare providers he'd seen in the aftermath of the surgery were disrespectful, and given his female trans male status. When I saw him in the ER, he looked broken. He was clearly in an impossible bind. He loathed the healthcare system, given the way he'd been treated by his providers, but he needed it given the severity of his post-op complications. I quickly realized that this consult was about much more than management and wound care. It was about a man whose trust in the healthcare system had been broken. He'd been laughed at, gossiped about, and dismissed by some of his providers. Walking out of the ER, I thought how this had been a moment in my training that I would always remember. I had never felt as valued, as necessary to the healthcare system as I did after taking care of this man. By virtue of being open, caring, and non-judgmental with him and his partner, I earned their trust. In turn, they were open to receive care from us. As he left, he felt a hand on his shoulder as he walked up the stairs from the delivery room. It was this man's partner. She turned to me and said, "Thank you for being the first gynecologist to treat him with dignity. That too, I will always remember." Medical students are encouraged to reflect in their first clinical experiences, but it's not just by having the experience. It's as John Dewey said, we learn from experiences, we learn from reflecting on the experience. I must say that this reflection, after having read it, had a profound effect on me in terms of making me reflect about my own cultural biases. How would I have responded? Was I one of those people that might have been disrespectful or laughed or made fun of? Many of us are uncomfortable in this situation. We feel awkward. We often make jokes. How was I insensitive? I realize that we all have these biases, and it's important that we're aware of them. And I think Terrie is going to now talk about blood donation and biases, and I will come back later and talk a little bit about laboratory-based biases.
Thanks so much, Ian, for that beautiful reflection. And, you know, really the experiences that were expressed in that reflection are fairly similar in other Canadians. So this is just a snippet from TransPulse Canada, which is a national community-based survey of the health and well-being of trans and non-binary people. And one of the main findings from the study that I think is really significant is that 45% of trans people reported having an unmet healthcare need versus 4% of the general public. And so that's really significant because that means a large portion are either not accessing care or have barriers to receiving care that really, you know, are not experienced by other non-trans individuals. And so it's been argued in the literature that a main driver for these differences in healthcare access between trans and cisgender people is stigma, underlying bias and discrimination. So as healthcare providers, it's really important for us to become aware of these sources of bias and stigma because the experience of stigma, whether intentional or not, in the healthcare system can really strengthen the authoritarian divide between the patient and the caregiver, and it can increase the uncertainty about the ability of the healthcare system to meet individual needs. And so my personal experience when interacting with other healthcare providers, including those who work in the donor center on this topic, is that the vast majority of people aren't trying to provide care that is culturally unsafe. They just don't know what to do. And maybe they're just not aware of their own biases themselves. And so to get a better understanding of this, the research that I'm doing in my graduate studies is really focused on exploring the experiences of healthcare providers and other people in helping professions in providing culturally safe care to trans individuals. So as part of this research work, we compiled a scoping review to understand broadly what is known about the knowledge and experiences in culturally competent care provision for trans individuals among healthcare providers. And because I work in a donor center, I wanted to also consider the applicability of these findings in the context of donor center operation, where no research about staff experiences currently exists. So as part of this scoping review, we performed an inductive thematic analysis, which revealed system gaps and practice gaps that really hindered relationships with trans people and diluted data for institutions, for research, and also for with public health data. And so some key themes from our scoping review are that the healthcare providers who were involved in the included studies described rigid binary, so male-female intake processes, and uncertainty regarding how trans individuals are identified in their practice settings. They also expressed difficulties knowing when to ask and when to use pronouns. Some of the individuals in the included studies described confusion and conflating of key terms and pathologizing or medicalizing trans patients. And then there was also some confusion regarding the prevalence or desire to have gender-affirming surgeries or medical interventions, and when and how to have this discussion about these interventions with patients. And there was also a lack of understanding of stigma generated by the healthcare environment for trans individuals, and really how stigma can elevate patient health risks. So all of these key themes, to me, really identify needs of the healthcare community in order to provide culturally safe and competent care for these individuals. And so some recommendations in the included studies were to create inclusive environments and records. Some of the studies suggested that we should ask all individuals their pronouns at the outset of a therapeutic relationship. To consider using a two-step intake process when trans patients must be identified. So that's when you must know that you have a trans patient. And in this two-step process, the idea is to ask all individuals first the sex assigned to them at birth, and second, their gender identity. And also they recommended institutional and purpose-built training material and training exercises regarding cultural safety and sensitivity for trans individuals. But it's really important to underscore that there really hasn't been any blood center specific research in this domain. And so I really think blood center specific research is needed, which could further improve the provision of culturally competent care for trans donors. So it's often discussed that trans individuals face many and far greater health and social disparities than cisgender individuals, including increased risk of physical violence, trauma, significant trauma from public harassment, increased rates of unemployment and homelessness, increased rates of substance abuse and tobacco use, higher incidence of mental health concerns, more suicide attempts and self-harm attempts, higher rates of HIV and other sexually transmitted diseases. And when looking at this data, it's important to think about why these disparities are so great in this population. And a growing body of research is really demonstrating that marginalization and stigmatization is a considerable driver for these healthcare disparities. So individual studies by several research groups have shown that the more gender identity discrimination individuals face, the less likely they are to use condoms, and they face higher rates of drug use, depression, and mental illness. And when resources to meet basic needs, such as safety, belonging, shelter, access to healthcare, and food are scarce, prioritizing other healthcare issues like HIV prevention and healthcare needs might fall below fulfilling these immediate basic needs of life. And the most important thing to recognize when we're talking about health disparities for trans people is that it's not gender identity or being trans that increases these disparities. And that interactions from those in helping professions can really mitigate or increase stigma for trans people. And in fact, research has shown that when trans individuals are and their identities are affirmed through inclusive policies, spaces, and appropriate transition care, that these disparities improve greatly. So beyond recognizing our own biases regarding gender and how they may be a barrier to culturally safe care, there are some other ways that we can reduce stigma in this group. And so one of the really important ways is that how we communicate and connect and interact with these individuals can really mitigate or increase stigma and marginalization. And what we do matters. So here are some practical considerations to improve interactions with trans individuals. And these were derived from the Canadian Blood Services Trans Diversity and Inclusion modules, which I'm going to talk about a little bit later, and also from the results of our scoping review. Pronouns are an important and often taken for granted part of conversations with people. So for people who are automatically addressed by their pronouns, this might seem unimportant, but for those who are constantly having to work to get people to use their pronouns, the issue of proper pronoun usage is of great importance. And early identification and proper pronoun usage has been recognized as a prudent first step in the literature to establishing effective communication with trans individuals. So some suggestions are to try and look for ways to incorporate pronouns in your introductions and think about ways to include pronouns in broader processes like intake assessment forms or when you're leading focus groups or different things. And a simple way to make sure that you have the correct pronoun is to use your own pronouns in introductions, which encourages others to identify theirs as well. So for example, hi, I'm Terrie. I use the pronouns she and her. How about you? Whenever possible, ask people which pronouns they would like you to use. It's okay to ask about pronouns. We can think of it like when you are using someone's name. Until you ask what it is, it's okay that you don't know. If you're unable to ask, you can use gender neutral pronouns like they and them. But once an individual identifies their pronouns, it's important to be sure to use those in conversations because not all trans individuals identify with gender neutral pronouns. So this is just a table of pronouns and how to use them in a sentence. And this is, again, this isn't an exhaustive list of pronouns. And it's important to remember that using pronouns is a cue to guide respectful conversation with trans individuals, but it's not necessarily an indicator of the gender that a person identifies as. So, for example, some non-binary people may choose to use she, her pronouns, or he, him pronouns, or they, them pronouns. So, but it is using a person's pronouns is a cornerstone of conversation and is really kind of the first step in having effective conversations with anybody, including trans people. So also, just like for everyone else, trans individuals' names are an important part of their identity. And it's important in interactions with trans individuals to use the person's chosen name in conversation, even if it's not the same name that appears on their identification or in their health records. And so there might be times where you need to use the name as it appears in the record or as it appears on legal ID, but it's always important to just explain the reason why you need to use this name, and to explain to the individual that you will use their chosen name in all other interactions. And it's important not to put chosen name in quotations or to put quotations around pronouns, just like you wouldn't for cisgender individuals. So this is just a table describing some ways to have culturally competent conversations with trans individuals, and some problematic statements to avoid. So when referring to the past, it's important to avoid saying things like born a man or a woman, when you were a woman or a man, because most trans people feel that they have always been the gender that they are. So instead you can say sex assigned at birth, or in the past, or when you were born, or last year when you're referring to a time pre-transition. And if you must ask about the past, it's really important to explain why you're asking. Avoid using the term real for legal name, as it implies that the person's lived experience and chosen name are less valid. So instead, if you must confirm the legal name, you can explain why you need to do this and refer to it as legal name, and really just use the person's chosen name during all other interactions. And you want to avoid using terms like sex change or really asking about surgical or medical interventions if you don't need to know. So asking about, medicalized and surgical interventions really overemphasizes the role of surgery in the transition process. So again, not all individuals have access to or want to have gender affirming surgery. So if you don't need to ask about gender affirming surgeries or questions about genitalia, it's best not to. Just like everyone else, it's kind of weird to ask somebody about their genitals if you don't need to know. And again, if you do need to know, always explain why you're asking. And then avoid using terms like transgendered or transgenderism, similar to how we don't say homosexualism or lesbian. These terms can really pathologize identities or medicalize identities. So using the word trans or transgender is more appropriate. So this is probably the most important point, which is we're all human and we all make mistakes sometimes in conversation. And there may be times when we use the wrong pronouns or the wrong name by mistake. And one of the best ways to correct this is really just to not make a big deal about it, to apologize simply and quickly, just a quick pardon me, and then repeat the correct pronoun or name, and make a sincere effort moving forward to use the correct terms. The most important thing to remember is that trans people just want to be treated with and spoken to like everyone else, with friendliness and respect. So the other really important point is that creating inclusive spaces is really important so that trans people will feel welcome. And this includes welcoming and knowledgeable staff. And it's important as part of that, if you need to leave the room to have a conversation with someone else or put a trans person on hold to consult with someone else, that you inform the individual why you're leaving, and you never have discussions, even if you think that they're well-meaning, about trans people within earshot. As far as trans inclusion goes, it's important that where possible, looking for ways to include diverse identities and signage, advertising, focus groups, and feedback is really important. And then if you're looking to make any policy changes or any decisions that really would impact trans people, involving the voices of trans people is so important, because sometimes individuals, well-meaning, if they don't have the same experiences as trans people, they might not be able to capture those lived experiences, and we might miss the mark with policy and decisions. And then just gender-neutral facilities and areas that foster inclusion in clinic environments. So now Dr. Chin-Yee is going to talk about providing care for transgender community and the laboratory role.
Thank you, Terrie. The question I asked myself in preparing this section is, are we part of the problem or part of the solution? So what is the laboratory's role in providing care for the transgender community? Next slide. So this is, there's actually a significant amount published on this, and the senior author on this, Dina Green, has been associated with a number of the publications that you'll see coming up. So when gender identity doesn't equal sex recorded at birth, the role of the laboratory in providing effective health care to the transgender community. And this as the table shows, the recommended laboratory practices for best practices for transgender care. Many of you may also be aware that IQMH has published a white paper which elaborates on many of these points. So what you find is the problem starts right at the beginning. Creating documents, your institution for identifying transgender patient. This document should specifically highlight several systems that indicate sex assignments. Examples include intake forms, LIS interfaces, and health records. At my institution, London Health Sciences Center, we do not have fields for sex assigned at birth and gender. In fact, we have a field that says gender only. So this is something we're working to change. Do not cancel laboratory tests based on assumed sex specificity. So just because someone is listed as male, as a sex assigned at birth, or male in gender, and they had an HCG order, don't assume that it was done in error. Ensure proper flagging for tumor and pregnancy-related markers are implemented without sex specificity. This one I find more challenging in the laboratory. What does one put in as a normal range for patients, transgender patients, patients in transition on hormonal therapy? And I'm going to talk a little bit about that. Provide diversity training to the phlebotomy team and ensure gender incongruence is a component. I must tell you that CBS has a training module. My hospital does not. And the last point, recognize there's different reference intervals for transgender patients have not been established. Therefore, hormone status and clinical judgment must be used in assessment of abnormal laboratory values. Next. So many of you may have seen this case report. Probably many of you in this room are not old enough to recognize the person on the left. And the person on the left is Jean Drapeau, who was the mayor of Montreal when the Olympics in 1976. And he was famous for saying that for the Olympics Montreal to go in debt over the Olympics isn't any more possible than a man becoming pregnant. So you see the case report for transfusion support for transgender men of childbearing age. The case report describes a 40-year-old transgender man who retained his uterus and ovaries and presented with a severe vaginal hemorrhage following biopsies of the cervical mass. This patient was listed as male but retained female organs and was transfused based on being a male. So the point here is that the person should have when they got uncross-matched group O blood, they should have gotten O negative blood and not Rh positive blood. So transfusion policy should include issuing type O Rh negative blood to any individual with an assumed ability to become pregnant. Now, I recognize from the transfusion medicine blood bank perspective, this is not always easy to tell. But the clue here is if the gender identity does not match the sex assigned at birth. It would be very difficult based on the intake forms at my hospital to be able to identify this patient. Next slide, Terrie. At London Health Sciences Center, normal ranges and flagging is based on the sex selected in our health information system. So it's the sex assigned at birth. We've looked at ways of dealing this. We could potentially remove normal ranges altogether. I would argue that would not be particularly helpful. We could have a combined normal range that includes both the male and female range, or we could put in both the male and female ranges with an explanation of the ranges, such as demographic populations can be very physiologically diverse, example, non-binary gender individuals. Reference intervals provided on this report may not apply to all patients. This allows the interpretation of a particular level, we're looking at hormonal level, in terms of the patient's context. So you need to recognize that reference intervals for transgender individuals may not have been established, and therefore hormone status and clinical judgment must be used to assess abnormal laboratory values. Interestingly enough, Dina Green who I mentioned earlier, has done a fair number of studies looking at reference intervals for the transgender population. And the picture here there on the right says, if you are a transgender man on stable hormone therapy, your reference intervals should look like cisgender men. Similarly, if you're a transgender individual who's on stable hormonal therapy, your hematologic values for a trans man is in the male reference range, and for a trans woman in the female reference range. Next slide.
Okay, so now I'm just going to finish talking about providing culturally safe care for trans blood donors. So I'm going to talk about how we screen trans donors currently and what we're doing to improve the donation experiences for these donors. And so Canadian Blood Services is committed to inclusion and diversity because, first, it's the right thing to do. And we want to create an inclusive culture based on fairness and equity and support and embrace diversity to also better serve the Canadian patients that we serve. And we want to ensure that all people who come to our donor clinics are treated with dignity and respect. So to ensure a consistent screening process for trans donors, Canadian Blood Services began applying donation criteria for donors who self-identify as trans. So that means donors who tell us that they're trans in 2016. And so this is similar to donation criteria that we have for hemoglobin or for men who have sex with men or for travel risk. All of our donation criteria is not based on an individual person's risk assessment, but rather on a broader category that the donor fits in. So in this criteria for trans donors who have not had lower gender affirming surgery are screened in the sex assigned to them at birth. If they have had lower genital gender affirming surgery, then they are deferred for 3 months following the date of surgery, and then they are screened by the gender that they identify as. And you can see in this table on the, I think it's the left, that the main screening questions that we ask a male donor are if they've had sex with a man in a given period of time, and for females we ask if they've had a male partner who's had sex with another male partner in a defined period of time. And so our trans criteria is really aimed to address two main considerations. The first is for trolley risk. And so, trolley is thought to be associated with potential antibodies that are acquired during pregnancy. And so to address this, all plasma collected from self-identified trans donors is used for fractionation only, thus reducing the trolley risk from a trans donor who may have had a past history of pregnancy. This also contributes to the supply of invaluable plasma that we use as a raw material that's transformed into plasma protein products, which, as you likely know, are in high demand worldwide. And the second consideration is HIV risks. So there is little information available on the risk of HIV in trans individuals in Canada. And this is because, unfortunately, trans individuals are not included in a separate risk category by the Public Health Agency of Canada in their annual reports on HIV and AIDS. However, there is some available limited studies that suggest that HIV infection rates in trans women may be significantly higher than in cisgender individuals. And so for this reason, currently at Canadian Blood Services, we consider trans female donors who've had a male sexual partner as being in a high risk category. And as a result, a trans female donor will be ineligible to donate blood for 3 months since her last sexual contact with a male donor. And so you can probably imagine that these criteria were heavily criticized by the trans community. So later in 2016, Canadian Blood Services conducted stakeholder consultations, bringing together a number of trans individuals from diverse areas of Canada, including donors and non-donors, to have an in-depth solutions-focused discussion. And several short-term and long-term action items were derived from these consultations. And one of the main recommendations was to create sensitivity training for all staff. And so out of this feedback, we co-constructed 2 LGBTQ plus and trans inclusion education modules and they were actually designed by members of the trans community leading this work. And these modules were rolled out nationally this past, 2 summers ago. And many of the best practice recommendations that were given in this talk were derived from these modules. We also held a multi-day syntegration session in 2018, bringing together colleagues from Canadian Blood Services from diverse departments and backgrounds, as well as diverse community groups and donors, including participants from the trans community, to provide valuable guidance exploring how we can attract and retain new donors, especially in Canada's most diverse urban centres. And we also attend Pride festivals in many communities across Canada to engage with the trans community. And we aim to really have open discussions at these events and answer questions from the community. And we hold many formal and informal stakeholder discussions at various community venues, universities and colleges, where we engage with the trans community. And probably the most exciting thing that I think is happening on the horizon is that there are 2 new studies that were recently funded through the Health Canada MScN research grant programs that are really aimed at understanding specifically how we can improve donation experiences of trans people. And so just to summarize everything, so pronouns are an important part of the conversation experience with every person, and it's okay to ask about pronouns. You can try to use your pronouns first in conversation. It's important to always use a person's chosen name. If you need to know something about the past, specifically related to transition or the experience of being trans, or any sensitive information, it's always important to explain why you're asking. If you make a mistake, apologize simply and quickly and move on. And as with all people, trans individuals are really important contributors to our blood system, and they deserve to be treated with dignity and respect. And this last slide is just a list of resources. The majority are Canadian resources, but there are a few international as well. If you want to learn more about how to provide inclusive environments for trans people, or you want to learn more about trans people, these are some really great resources. And so that's the end of our talk, and we'll be happy to answer any questions.